G'day. This presentation identifies and discusses the legal, ethical, and professional practice issues involving a patient by the name of Bert and his two treating doctors, Dr. Ling Chen, the new intern, and Dr. Johnson, the rural GP. Bert is a farmer who suffers from chronic non-malignant pain and seizures. Dr. Johnson's approach to treating Bert's chronic pain is with codeine, an opioid which has been prescribed for over a year. He also prescribes clonazepam, a benzodiazepine, for the treatment of Bert's seizures. Dr. Chen is concerned for Bert's dependence on codeine, as he has been using it for over a year and notes the precautionary nature of prescribing opioids with benzodiazepines simultaneously. Her good-natured advice and concern towards Dr. Johnson's prescribing practice and Bert's dependence to codeine is proudly dismissed by Dr. Johnson. Dr. Johnson has developed a friendship with the locals and with Bert over his years of rural practice. Later on, Dr. Johnson and Bert attend dinner together, and Bert subsequently suffers a car accident due to drink driving. This lays a background on which I will highlight the legal, ethical, and professional matters in this case. I will begin with the legal issues arising from the case. The key issues include potential for professional misconduct, misuse of prescriptions, and negligence. According to Section 5 of the Queensland Health Practitioner Regulation National Law Act, professional misconduct can be defined as more than one instance of unprofessional conduct that, when considered together, amounts to conduct that is substantially below the standard of practice for a registered health practitioner. One could argue that Dr. Johnson may have acted unprofessionally on many occasions, which amounted to professional misconduct. Firstly, Dr. Johnson overstepped professional boundaries with patients, as highlighted by his barbecue to meet the locals, or his quote-unquote patients, and his plans to meet Bert at the Bowls Club for dinner, which overstepped the therapeutic limits of a doctor-patient relationship. Secondly, Dr. Johnson may have prescribed Bert opioids in conjunction with benzodiazepines without the full consideration of side effects. According to the AMH, opioids with benzodiazepines should be prescribed with extreme caution, as there are severe consequences such as respiratory and central nervous system depression from misuse. And to add to that, opioid medications may exacerbate seizures, which Bert suffers from. Furthermore, Dr. Johnson may have prescribed medications inappropriately. The first occasion was Bert's opioid prescription. ROCGP suggests starting with non-pharmacological treatment plus minus non-opioid adjuvants, then carefully considering opioid medication. It could be argued that Dr. Johnson unnecessarily prescribed codeine before considering other options, especially in the context of Bert's seizures. Bert had also been interested in pursuing a non-pharmacological approach, which was apparent during Dr. Chen's consultation. The second occasion was Bert's clonazepam prescription. ROCGP states that benzodiazepines have limited usefulness in long-term management of seizures, due to the rapid development of tolerance to anticonvulsant effects and development of associated side effects. Rather, other prophylactic anti-epileptics such as phenytoin should be used. This was important as poor seizure management could lead to a suspension of Bert's license or a potential driving accident. Lastly, there are indications that Dr. Johnson potentially omitted critical information when prescribing benzodiazepines and opioids for Bert. Following the fact that Bert was driving and consuming alcohol even after the prescription of opioids and benzodiazepines. According to the AMH, driving, operating heavy machinery, and consumption of alcohol are contraindicated when taking these medications. Both drugs cause sedation, and therefore can be dangerous during driving or operating machinery. Alcohol with these drugs may exacerbate this sedation. However, there is the possibility that Bert was in fact informed by Dr. Johnson but chose to disregard his advice. This is very unlikely, as most reasonable people would value their lives and take necessary precautions against the severe risks posed by this drug. This follows into healthcare complaints. Dr. Johnson most likely falls under mandatory reporting by placing the public at risk of harm by practicing the profession in a way that constitutes a significant departure from accepted professional standards. We have discussed how Dr. Johnson breached professional standards, but how was the public placed at a risk of harm? Apart from Bert, Dr. Johnson had other patients which may have had questionable management. This can be demonstrated by the narrative. The nurses warned Dr. Chen that she shouldn't question Dr. Johnson about the patients because he can get really angry, or later on, Dr. Chen told Bert she could not prescribe codeine to another one of Dr. Johnson's patients. The way in which Dr. Johnson conducted himself with Bert and their doctor-patient relationship was unlikely to be different with other patients, which can be drawn from his backlash, "You don't know how it's done in the bush," towards Dr. Chen's concern regarding Bert's treatment and prescribing rules. This implies that Dr. Johnson's malpractice likely put other patients at risk of harm. Moving on, Dr. Johnson potentially failed to comply with the prescribing rules set by Queensland Health Drugs and Poisons Regulation 1996. Section 213 of this legislation states that if a relevant practitioner reasonably believes a person is drug dependent, the relevant practitioner must not dispense or prescribe a restricted drug of dependency for the person without approval. Codeine is a restricted drug of dependency. Dr. Chen had legitimate concerns regarding Bert's ongoing dependence on codeine, as he has been on the drug for over a year. However, within the narrative, there is no explicit evidence to suggest that Bert exhibits any drug-seeking behaviors or impaired control. While he has been on the drug for over a year, he simply asks for his script of codeine and seems to take aboard Dr. Chen's advice regarding non-pharmacological treatment. These are not red flags of substance use disorder highlighted in the DSM-5. Although Bert does not seem to meet the definition of a drug-dependent person outlined by the Health Act 1937, there are concerns that he may be. Dr. Johnson should have taken this concern seriously by discussing with Dr. Chen and assessing Bert's dependence to codeine, before prescribing any restricted drugs of dependency to Bert. His action of dismissing Dr. Chen's concern and immediately prescribing for Bert raises alarms regarding his prescribing practice. Next, negligence should be explored in this case in the context of Bert's traffic accident and Dr. Johnson's potential omission of care. The Queensland Civil Liability Act 2003 states that to successfully claim negligence, the relevant practitioner must fulfill the criteria of duty of care owed to the patient, must have breached the standard of care, must have factual causation, and must have suffered a quantifiable and recognizable form of harm. Dr. Johnson owes Bert a duty of care as his treating GP to warn about the consequences and contraindications of using benzodiazepines and opioids. Dr. Johnson breached his duty of care as his failure to warn of medication-induced drowsiness could have led to a foreseeable and real risk of harm, and this risk was not insignificant as serious injury or death could ensue, and a reasonable person in this circumstance would have taken precautions to avoid this risk. A recognizable and quantifiable form of harm was evident in Bert's traffic accident. However, factual causation could not be determined. Although Dr. Johnson's potential omission of advice may have resulted in Bert's continued driving and alcohol consumption, Bert's car crash was a result of his drink driving, as it was stated that his blood alcohol level was above the legal limit of 0.05. Bert was solely responsible for his decision to drink drive, and so the failure to warn of medication risks was not a necessary condition for this particular accident. Moving on to the ethical issues pertaining to this case. Doctors possess legitimized referent and expert power compared to patients, and there are ethical consequences of breaching professional boundaries. Dr. Johnson breached professional boundaries by forming relationships that overstepped the therapeutic relationship between doctor and patient, portrayed on occasions where he invited patients for a barbecue at his house or when he planned to meet Bert at the Bowls Club for dinner. The nature of a doctor-patient dynamic tends to be asymmetrical, as there are aspects of power, patient vulnerability, and unconditional trust that may be taken advantage of when boundaries are breached. Moving on, non-maleficence is the principle of preventing or minimizing harm done to patients. Dr. Johnson has contravened the ethical principle of non-maleficence by potentially causing harm to Bert through 1. Prescribing opioids with poor consideration of its interactions with benzodiazepines and with seizures, 2. Potentially failing to warn of the risks and precautions when taking these medications, and 3. Unnecessary or inappropriate prescription of medication in the instance of failing to consider the first-line non-pharmacological approach to treating Bert's pain, or prescribing benzodiazepines where it may have been a poor choice for long-term seizure management. Autonomy is a competent adult's capacity to make informed decisions about their own health. A lack of informed consent contravenes patient autonomy, as it may alter decision-making of the patient. Dr. Johnson potentially admitted the risks of benzodiazepines and opioid medication, and this would indicate a lack of informed consent before prescribing Bert's medications. As a farmer, if Bert had known of the consequences of opioids or benzodiazepines and their implications on driving, drinking, and operating machinery, he may have chosen to explore different treatment pathways instead. And lastly, this case underlies inequitable treatment in a rural setting versus metro setting. Dr. Johnson points out you don't know how it's done in the bush. This remark is a reflection of the differences in practice between rural and metropolitan doctors. A comparative study done by Britt et al. Found that statistically, rural GPs were more likely to provide prescriptions without seeing the patient than their counterparts in metropolitan areas. Counseling and advice were recorded far less often in rural areas. Ethically, this differing in practice points to underlying issues in treatment philosophy rurally versus metropolitan, highlighting perhaps the effects of less governance, less healthcare resources, and greater strain on rural doctors that may have resulted in more unfavorable practices. So moving on to professional issues. Firstly, patient-centered care. The Code of Conduct section 3.2 states that ensuring adequate knowledge and skills to provide safe clinical care, good communication, recommending treatment on a basis of benefits versus harm, consulting with colleagues, ensuring your personal views do not adversely affect patient care, and abiding by therapeutic guidelines are integral in good patient care. Dr. Johnson has contravened patient-centered care on multiple occasions. These include the prescription of benzodiazepines and opioids without full consideration of drug interactions or contraindications, omitting the risk, precautions, and consequences of taking these medications, recommending therapeutic treatment when it may have been inappropriate, for example, prescribing opioids to a seizure-prone patient or recommending opioids before non-pharmacological options, having a personal bush medicine view on practice that adversely affected his patient care. Dr. Johnson not only refused appropriate, well-intended advice from Dr. Chen, but did so with irritation. All these elements result in an undermining of patient-centered care. The Australia Code of Conduct states that professional boundaries are key to good doctor-patient relationships. As mentioned in ethical issues, Dr. Johnson has breached professional boundaries as he developed a relationship with Bert that goes beyond the therapeutic limits and potentially with other patients as well. Breaching the therapeutic relationship consequently hinders patient care. Lastly, onto the topic of professionalism in teamwork and respect for medical colleagues and other healthcare professionals. Dr. Johnson failed to uphold these qualities in the narrative. For example, he tells Dr. Chen to mind her own business after she voiced her concerns for Bert, stating, "You don't know how it's done in the bush, I'll handle it." To add to this, nurses also seem to be intimidated by Dr. Johnson, advising Dr. Chen to avoid confronting him about his patients, in fear of angering him. Thus, Dr. Johnson's conduct discourages teamwork or effective communication between colleagues, and this may impede patient care. So on to parties involved and potential consequences. The involved parties of this case include Dr. Chen, involved in the care of Bert and intern to Dr. Johnson as the main treating doctor for Bert, and Bert as the patient looked after by Dr. Johnson and Dr. Chen. Let's begin with the potential consequences affecting Dr. Chen. She may have self-blame following Bert's accident and feelings of guilt. She may also suffer anxiety towards the expression of her opinions in practice due to Dr. Johnson's intimidation. This may lead to adverse care stemming from impaired communication between colleagues, apprehension towards challenging Dr. Johnson's practice, and fear of reporting mistakes. Finally, as a senior doctor and role model, Dr. Johnson's practice may negatively influence Dr. Chen's future practice model. For Dr. Johnson, potential consequences include legal ramifications of professional misconduct, such as reprimanding, restriction or supervision of practice, or even suspension. Furthermore, there may be professional consequences such as a loss of trust in the doctor-patient relationship, compromised communication between colleagues, and compromised patient safety. For Bert, there may be a loss of trust in doctors and apprehension towards the healthcare system. Bert's health and safety were potentially at risk in this case, as continued drug prescription could develop into physical dependence to codeine or benzodiazepines, or worsen existing drug dependence. Or poor prescription practice could lead to serious injury and death from Bert potentially driving under the influence of his medications. To address how this case should be managed, firstly, Bert's immediate well-being and best interest should be addressed following the accident. A detailed explanation of what, why, and how regarding his substandard treatment should be given to Bert, and an apology should be delivered. A formal pathway for complaint should be offered. Dr. Chen should undertake reporting of Dr. Johnson's professional misconduct to the Health Ombudsman. Dr. Johnson should be subject to disciplinary actions by the Health Ombudsman and QCAT, including reprimanding, reformation of practice, undertaking imposed conditions on his registration, and possible suspension. Following this, Dr. Chen and Dr. Johnson should endeavour to form a proper management plan for Bert's ongoing chronic, non-malignant pain and his seizures. Bert should be given autonomy when making decisions, and it is his choice to transfer management to a different GP if he so wishes. Bert should be properly assessed for drug dependency to codeine or benzodiazepines. A proper stepwise management for Bert's chronic pain would firstly include exploring non-pharmacological options plus minus adjuvant analgesic. If this does not work, informed consent should be obtained before prescribing Bert a trial of opioid prescription. If Bert is evaluated to be a drug-dependent person, approval from the chief executive should be obtained before prescribing opioids or benzodiazepines. Bert's benzodiazepine should only be prescribed for acute episodes of seizures. Rather, a prophylactic anti-epileptic drug such as phenytoin should be prescribed for long-term seizure management. Informed consent regarding his medications must include the contraindications, precautions, side effects, and potential consequences if non-adherence occurs. So why is this case important? This case is important to review as it highlights two major topics: professionalism in practice and adverse medication events in medicine. As a developing doctor, a crucial part of growth is building a strong moral base of practice. This case highlighted a number of professional issues in practice, an example being breaching professional boundaries. Essentially, these issues emphasize the importance of professionalism and consequences when professional standards are not achieved. In turn, this leads to developing a frame of mind for patient-centered care, good teamwork, and trustworthy doctor-patient relationships. This brings me to my second point, medication-related problems. A 2013 literature review on medication safety in Australia had found that 10% of patients seeing a GP had had an adverse medication event in the previous 6 months, and the level of potentially misused medication in the community was at 21%, highlighting the magnitude of medication problems. Drug dependency and drug-seeking behaviors especially have been a big factor in adverse events with medication. RACGP states that when dealing with substance misuse, many GPs find it difficult to intervene, difficult to maintain proper boundaries, and difficult to avoid manipulation. Emerging drug problems such as methamphetamine use, medicinal cannabis, electronic cigarettes offer new challenges in medical treatment. As such, having an awareness of these problems and the legal, professional, and ethical aspects can prepare developing medical practitioners to tackle the ever-changing face of substance use in Australia. Thank you very much.